information.
How many people do you think know about this?
We know that most people don't know that. So no, we bring out new national guidelines. So in that will be the sort of explanation of how we understand why people are overweight, and it's not their fault. It's part of the process of living in this lovely environment.
So here we are, Wayne. Thank you.
Pleasure.
Nice to see you again. It's been a while. Since 5 minutes ago. No, it's been a while. It's been a while, and I'm sure you've been very busy.
Correct.
You and your wife, Tracy, you run the Center of Diabetic Excellence. Yes.
So we got a diabetes clinic. So I work here, Tracy works next door, and then she's got educator and dietitian next door as well.
Okay.
And then we also got, as a side link, we got our weight loss bariatric clinic coordinator next door as well. But yes, we run as a team in terms of the diabetes.
You're the gurus on managing diabetes and diabetes patients.
We try.
You try. You mean it's you and the patients, because you both need to be working together. So let's have a look statistically. Talking about diabetes increases. Have you seen has there been an increase? I'm sure you guys look at the stats.
So there's an increase. So obviously the population of South Africa goes up. As the population goes up, there's an increase in the number of patients with diabetes. But if you look at the percentage as well, that's going up. So of the population, the percentage is going high, which means more people are getting it up as well. So yes, we have an issue in terms of diabetes numbers.
Yes, and I mean, it's true to say, looking at the Discovery stats, because we manage the Discovery health claims, so we've seen increase in cancer, we've had an increase in heart disease, heart attacks. No one can understand why this last couple of years has seen such a big increase in these.
So part of the problem is, we've got more diabetes out there, but what's driving the diabetes epidemic or pandemic is the obesity epidemic and pandemic. So there are more people who are overweight, that leads to more diabetes, but overweight in itself also leads to a higher risk of cancers, heart disease, kidney problems, fatty liver problems. So obesity is probably the big driver of diabetes, and then all the other issues that we're now seeing down the line. So that's a big driver.
How do you define obesity?
So interestingly, it's changed.
Okay.
So we used to define obesity based on the BMI, so that's your weight corrected for your height. And so we used to use between 18.5 and 25 as normal weight, and if you're 25 to 30, we called you overweight, and if your BMI...
25 to 30, your body mass index, okay?
Correct, your body mass index.
Yeah.
And then if your BMI, again, more than 30, we called you obese.
Yes.
The problem is the definition has changed, and it will change. We're bringing out new SA guidelines, which will be in keeping with this change of how we understand it. We now define it as a chronic condition of excess or abnormal body fat, which means it's not then based on BMI. You've got to look for excess body fat in different ways, and the way we do that at the bedside is we put tape measures around waists. We look at what your waist circumference is. We look at your waist to height ratio. So what is the waist relative to your height? And we look at your waist to hip ratio as well. And what we're trying to do is look for the bad fat, which is sitting inside the abdomen.
Yeah.
Because that's the abnormal or excess body fat that we're looking for, which means now you could be somebody with the old definition of BMI of 25, where we would have said you're now normal weight. If you got a raised waist circumference, you actually have obesity. So we're now picking up people with lower weights who have obesity because they're sitting with abnormal fat in the wrong places. So the whole way we understand obesity and the way we're defining it is changing.
Okay, and would you say that's causing some of the higher trends in
yes, so there's
heart attack, diabetes, cancer, etc.?
Yeah. So where you carry your fat and how much you carry is a problem. So you can have fat that's sitting around the heart, and that's going to put you more in risk for heart problems. You might have it sitting in your liver. That's going to put you at higher risk for liver disease, and even that can go into cirrhosis and to liver cancer. You can have it in the pancreas, and that can cause problems with your insulin, so diabetes. So depending on where the fat is and how much you've got and how badly it's functioning. So we talk about concepts of what's called sick fat and fat mass. So sick fat is where you've got fat that's acting abnormally and now it causes hormonal problems, inflammation problems. Fat mass is where you've just got too much weight, and so now that's putting pressure problems like on your joints and things like that. So when we look at weight, we look at it in terms of the so-called sick fat and fat mass problems.
Well,
so it's a very big conceptual change in the obesity world, how we understand things.
so you could have someone, for example, that is not in their minds obese or looks normal.
Based on a BMI, correct.
But they could actually be carrying this
Yes.
fat around their organs that
So
they don't know about, or do you
yes,
think
they
don't
may
know
not know
about
about. So we've kind
Okay.
of known that this is an issue for a while. So if you look at Asians, for instance, it's well known that they can have normal BMIs but carry a lot of fat in the abdomen. So we've always known that there's been cultural and differences from that side. But it's never been looked at beyond that in other people as well to say that they may also now be carrying excess body fat. So yes, now we know that you could be sitting even with a BMI of 24 and you can have type 2 diabetes because you just genetically or for some other reason carry excess body fat in the wrong places.
where you wouldn't see it.
Where
Is
you
that what
wouldn't see it, so they wouldn't see it, correct.
So someone like yourself, wouldn't say you're
So
fat.
then I could, yes,
You
exactly.
could have this. Okay.
Very much so. So that's why our understanding makes us look at everybody now. So what we do is we used to look at people and walk the door and you could see they were clearly overweight. So then we used to start thinking weight-related problems and so look at the show. Now we've got to look at everybody and say that actually until we assess them properly, we don't know whether they carry excess body fat or not. So we've got to start thinking differently.
So carrying excess body fat. Okay, so that's excess body fat around your organs. I mean, that's what we're really talking about. Because if you look at someone like yourself or someone like me, we don't look like we're carrying excess body fat.
Unless we go measuring and looking specifically for it.
And how do you do that? So how do you measure? And when you say look, because for example, just take a normal person that's going to gym now and again, that's having their 2 glasses of wine every second day. They think they're normal. So what should they be doing to go and check?
So that's where we will look at, so we'll look at their weight, we'll look at their height, but we'll pull out tape measures and we'll do that waist circumference and see. So we have sort of ideas. So for instance, you had very high risk of problems if in men your waist circumference is more than 102 centimeters, and in women if you 88 centimeters. And then if you're not at the very high risk, but you at slightly higher risk, so not normal, then it would be in men waist circumference about 94 centimeters and in women about 80 centimeters. So once you start hitting those numbers, that means you're carrying potentially fat in the wrong places. So we're using waist circumference and then we look at your waist to height ratio.
Yes.
So we can measure again around your waist and we measure your height. If your waist to height ratio is more than 50%, so if it's like 52%, then you're carrying relatively too much.
So let's just work that. So I'm 1.89 meters.
And your waist.
And my waist, who knows? Well, you can check afterwards.
So then we would look at your waist to your height and we would say relative you can, and that's your BMI might be in a sort of normal, or you might be just slightly overweight, but if your waist to height ratio is up, that means you're carrying more in the wrong places.
Okay, so what I'm hearing you saying, if I'm correct, is that for all of us, we need to manage our body fat.
If you can,
If
yes.
you can.
So we'll come to that, but yes. So if you can, so you want to reduce body fat, but so
is that what's causing diabetes? I mean, this is because we're talking about diabetes. I mean, someone with a high body fat has got a higher risk of diabetes. Whether it's now or they don't have diabetes now, down the line they could actually have diabetes.
Correct.
Type 2, obviously.
Yeah. So if you carry more excess body fat and in the wrong places, so in the what's called the visceral or internal fat and around organs, as opposed to just beneath the skin, which is your subcutaneous fat, that's not the bad fat, then you're at higher risk for all these metabolic issues. So diabetes, blood pressures, cholesterols, liver problems.
Heart attacks.
Correct.
Cancer.
Yes.
Okay. Well, that's interesting.
So how we view now is very differently. So the BMI, we're moving away from that as a marker.
Because I've always felt that was out.
Yes.
When I used to go for my Discovery Vitality tests, to try and up my vitality status, it always said my BMI is completely too high. And I used to think, well, where?
So that's because if you're a bodybuilder, you're going to have a lot of muscle. Every bodybuilder has a BMI that's above normal.
Yes, I'm not a bodybuilder, but yes.
But they'll have, so they'll all have a higher BMI, but it's not unhealthy. If you look at their waists and you do scans and you look for abnormal fat, you're not going to find it.
Yeah.
So the BMI is misleading. So we've always known that. Yeah. So there are problems with it, and that's why we're trying to define excess body fat differently.
Okay. Last time we spoke, I think it was about a month and a half ago, you said also, because you guys have been asked by Discovery to check that there's been the increase, reasons for the increase in heart disease, those kind of things.
You mean, so why is it going up higher?
Yeah.
So we live in a very toxic environment. So
what do you mean by that? When you say we live in a very toxic environment, I mean, yes.
So
is the food, is it stress?
So it's all of that. So there's food and how we produce it, what we're putting into foods and how we're processing them. And even things that it's even got our food, it comes with a whole lot of additives that we don't want. So recently, maybe last year I think it was, they looked in the arteries of people and they actually took little biopsies and they found pieces of microplastic. So we're even seeing those sort of things infiltrating into the diet and then coming. So cutting up on like plastic boards where you're cutting up your meat, a little piece of plastic might go into your food. You then consume the food, you're now getting plastic and whatever other chaos has come in with that plastic. So there's stuff in our diet that we inadvertently are taking. The processing of foods is not good because they have an influence on how the body reacts in terms of pushing out more insulin to cope with processed foods and high carbohydrate foods, and that we've got more saturated fat in our diet, we've got too much salt in our diet, we've got too little protein in our diet. So your body needs a certain amount of muscle to fat ratio. So you can get people who are very overweight but they have very little muscle. We call that sarcopenic obesity. Sarcopenia just means you've got little muscle. So they're carrying relatively too much fat to muscle. That's a bad thing. So all of these things that we're taking into our diets are having an influence in terms of our heart risk, but also in terms of how we're storing and how we're processing fats and sugars in our body as well.
I just want to ask you, based on what you're talking about, this diet, the food that we're consuming, does it make a difference when you've bought this food? I mean, if you just shop, not knocking any of the Woolworths or ShopRites or, but I'm just saying, does it really make it? I mean, of course it makes a difference, maybe.
I don't think, they're all wrapping in plastic and they're all
Correct.
using something. So those things are all getting into the diet across the board. So unless you're literally eating out the ground and eating directly from them without packaging, then you're going to get some exposure somewhere along the line. And even then, it depends on how they're growing it and what pesticides they're using. So if you're going organic without all other things in it, and then you're not wrapping it, and so you're getting it straight from there, that's probably going to be your least. So sort of
like from farm to market, at least,
Farm to mouth, basically.
Farm to mouth, sorry, that's what I meant.
So so that's a problem. So that's part of our so-called toxic environment. So that to change that is going to take huge sort of input from government. So that's not going to be at an individual level because you're surrounded. So they've done studies where they look at people who stay in areas that are surrounded by fast food places. So that's just your environment. So you're more likely to eat what's in your area because when you come home and you're tired and that you're going to go for what's convenient. So those people tend to be more overweight. But if you've got people living in places where they've got less fast food and more healthier, so just where they live is better, they eat better and they're less overweight. So your environment influences what you eat. So to change that environment, it's not something you can do. You can't go out and change the stores that are around you. That takes regulation to do that, and that's government regulation.
That's not going to happen in a hurry in any case.
Yeah, so that's a huge, prevention is a massive problem to sort out because there are many moving parts, lots of politics, lots of money, lots of things happening. So it's left to us almost at an individual level to try and manage our own wills because we're not going
to maybe be careful where you're buying, where you're shopping, what you're eating.
Yeah, but you can only have. So we try, but the control there, literally, we have very little.
Yeah, because everything is basically wrapped in plastic, basically, unless you go to a farmer's market and you buy in there, and they'll give you. Okay.
So we're surrounded by toxic stuff that we can't change.
So we're surrounded by toxicity in our food, right? And mental and stress Is that making any difference or not?
So we know this post-COVID as well. So there's a lot more mental issues. So that's definitely gone up. So the world is an environment for increasing stress. So people are much more stressed in their jobs. There's much more pressure related to that. There's much more pressure in children from school already trying to work out where they're going. And then there's much more pressure in terms of getting into universities and technicons. The numbers, the applications have gone up, so they can only take so many. So that there's already stress there. They're under pressure from parents and teachers, and then that continues into the workplace. So stress is a big one, and stress is just a slow ticking time bomb. So you can cope with stress for a while, but eventually you just can't cope anymore. And so that leads to big anxiety issues, panic attacks, depression, so lots of mental issues. And when you're depressed, then your body as well doesn't function as well. It makes you more prone to other metabolic problems. So there's a big tie between things like depression and obesity. So people living with obesity are more prone to depression, but if you've got depression, you're more prone to obesity. So the two drive each other, and that can be with lots of
And that
chronic.
can also lead to diabetes being increasing.
Correct. There's a lot of interplay.
It's like the
between
world's
them.
against us. It's better to go live on an island and surf or something.
It's very difficult, correct.
Yeah.
Our environment is very difficult. It's a very difficult environment.
I've seen a massive change since, I'm 60. So if I go back to when I was 40, even the last 20 years, it's insane, actually.
And I can't see that abating because
No.
I don't see any attempt to make it abate. So people.
But how do you get it? How do you do that? If you look at the cost of living, the price for young people to get into the property market.
So the disparity is correct. Yeah. So the property prices and the income, so it's a problem. And so it gets more because in places like Japan, for instance, they got a massive aging population. 1/3 of the population are above 60, but they haven't got enough young people to support the old people. So they've got negative population growth. They're the first country who's sort of going through this, but a lot of other countries following this. So you've got a whole lot of young people who are now trying to support the older people, and they're too many. So medicine's keeping the older people alive, but it's not helping the mental health of the younger people who need to cope with it. So it's a problem. So we have lots of issues they're very complex, and we definitely don't have the answers.
Because I don't think there is an answer.
No.
Yeah.
No. So it's very difficult. So I don't have the answer. I think everybody's got to decide where things help them. So in me, I draw certain lines at certain things, and I'm happy to say no to certain things, because if you keep doing everything, you just keep chasing your tail. So you have to draw lines in your world, but I don't have the perfect answer, no.
Someone that's been diagnosed with diabetes, what would you recommend to them? Obviously there's the diet. So is that one of the most critical things? Diet, exercise?
So it depends what your end point is. So if you're looking for health, so you want to be healthier, so you want to have less potential risk of heart attacks, strokes, and try and help blood pressure, quality of diet is important. So the types of things that you eat then are very important, and qualities like exercise. Exercising is good for health. If, however, your priority is weight loss, because there are a lot of patients with type 2 are overweight, then the priority is quantity, and that's a whole different ball game. So people can try and work on quality for the health, and we do that. So lower carbs, not zero carbs and not no carbs, to try and help the sugars will certainly be helpful. So quality changes, exercise for health. If you now want weight loss, you need to be reducing quantity, and that's where the problem is. So the problem is that people who are overweight, most of the time the reason why they're overweight is they have an appetite issue. So an appetite issue can happen for many reasons. It might be genetic, there might be part of these dietary changes that ultimately result in an appetite issue. So all these things that go into our diet, they can eventually influence how our body works, and part of that is influencing at the appetite center.
So I just want to say, some of the stuff that's going into our food is actually can influence the way that we have an appetite, so you can actually cause you to be more hungry. That's insane.
So that definitely can happen.
Yeah,
so
that's crazy.
And if that's part of the problem, then you get to a point where there's almost a point of no return. So now your appetite's up and you're eating. So everybody says, well, just eat less. But you can't. Yes. So if your body has a certain appetite level, that's what it wants to keep. So the way I normally explain it is, most people breathe about 14 breaths a minute. So that's what your body wants to do. That's homeostasis, where your body likes to maintain a certain level of something. So if you're breathing at 14 breaths a minute, and that's what you want to do, if I now ask you to breathe at 3 breaths a minute, I'll say engage your front of your brain, you go for 3 breaths a minute and see how long you can do it. By the time you're out on the road and you're sidetracked, your brain will go back to 14 breaths a minute, because that's what your body wants.
Yes.
Appetite in obesity is the same thing. Your body wants a certain appetite. You can try and change it, and you can say, I can do this, we can do this, we can do and get this better. You can do it for a while, and some people can do it for days, hours, weeks, some people go months, and some people go longer. But eventually your body's going to revert back to what it wants. However, it gets even worse. So when you cut quantity, so you give the body less food, and now it's wanting this X amount of food because that's what the appetite wants, is your body does 2 things when you give it less quantity. One is it turns down metabolic rate. It burns less calories, so you're burning off less. 2, because it thinks it's going into famine, it makes you go and seek food, so it increases your appetite hormone. So now you're sitting with an excess appetite, you start giving less food, and that increases your appetite, so it makes it worse. So what happens is your body,
You get more hungry.
You get more hungry as you try to give it less food.
Yeah.
So people feel more hungry, and then they sit there and it wears them down. So eventually, so everybody can lose weight. That's not a problem. The problem is maintaining it. So people can lose these. You've got the underlying problem of appetite. You've got the counter-regulatory appetite getting even worse. So people lose and then they bounce. And then they go to plan B. They lose, they bounce. And that's the cycle. So that's why we've seen it for years. So, and you can see everybody, they'll appear in the front page of the You magazine, lost 50 kilograms. You go to them a year later, they don't appear in You magazine again because they back up again. So they did this in The Biggest Loser. So The Biggest Loser, they locked them up. They set trainers onto them, dietitians onto them. They took away all their food, and people losing massive amounts of weight, 50, 60 kilograms over a period. And they did, the medical people then followed them post The Biggest Loser after they left the house and they went out into the world. The weight had gone down in the house, and they all just bounced back up again, because your body is now primed for weight gain.
It's not what they necessarily want.
No, but
it's not in their control.
No, it's not in their control.
Because I think a lot of people look at people and we blame people. I know, why can't you get your act together? Can't you just do this?
Correct.
It's not that.
No, so that's very much how we understand it.
Yeah.
We see it as not your fault.
Yeah.
So your appetite is what it is. You can't change
that's a
it.
good thing, because a lot of people think it's their fault, and then they become depressed on that, and then you start taking antidepressant medication.
Correct.
And that also slows your metabolism down.
So we call that weight bias internalization, where people have told you that it's your fault, so now you sit and you believe it's my fault, and if my weight doesn't get better and they've told me what to do, it must be my fault. So we're now turning that narrative around and say it's not your fault. This is how we understand weight, appetite issue. These are the counter-regulatory mechanisms. And so now if you want to lose weight, we have to use something different. So the eat less, move more approach doesn't do anything for your appetite. It doesn't reduce your appetite. And by cutting the quantity, it actually makes the problem worse. So doing exercise and diet by itself, because we'll come back to why I say by itself, is not going to get your weight down, and it's going to make it actually worse. So when we're doing diet and exercise, we're again interested in quality, because that's health, exercise because that's health. But weight loss is a quantity game, and when you reduce quantity, you run into problems. You lose, you gain. So diet doesn't treat appetite, doesn't treat counter-regulatory mechanisms, which is why we come to the new treatments and the way.
Can I ask something on that?
Yeah.
Because, we've all heard about the carnivore diet, because you're basically cutting out a lot of the carbs.
Quality change.
And now you're eating more of the meat, so what about that?
So that's a quality change in diet.
Okay.
So Banting, paleo, keto, Weightless, Weight Watchers, all of these things, they change in quality when weight loss is a quantity game. So if you change quality, and so say you're eating 2,000 calories a day and your weight is 120 kilograms, and I change you to a carnivore diet, but I keep you at 2,000 calories a day, you won't lose a stitch of weight. The quality of the diet is not going to make you lose weight. You have to drop quantity. So all the diets like carnivore, keto, that way
even though you cut out
weight.
the carbs, even though you cut out the carbs, which is the sugar, which
correct.
That's great. That's okay.
So if you're eating 2,000 calories, you're having 2,000 calories.
Okay.
So none of those, when they've done reviews looking at different quality changes to diet, one against the other, it makes no difference for weight. weight is a quantity game. You have to so if your issue is your appetite and making you eat more calories, you have to have less calories. The problem is you can't change your appetite, and your body counter-regulatory mechanisms you can't change either.
It sounds
So
like you're stuck
to,
in a never-ending cycle.
But we know this because we've seen people over the years. They lose
but
weight
on the
and gain
YouTube
and
channels
lose and
that
gain.
I've seen out there, they're always telling people, "Well, this person's
No,
lost
because
so
they're all
much."
short term. So all of them
Okay.
that appear on there, you got to go to. I've got lots of patients who have been way less than Weight Watchers managers who have run programs, lost weight, and then they gain and they end up on my doorstep. So we've seen this over the years, this bouncing of weight, and this is why it bounces, because we hadn't understood before how weight works. Now we have a much better understanding. Appetite issue, counter-regulatory hormones. So we have to treat those.
Okay, so how are you treating someone that is not 130 kilos, let's call it, someone that's 85, that wants to lose weight? Because they're worried about getting diabetes.
We'll say they're pre-diabetes and they don't want to get to diabetes. So then we have to improve weight. So we have to then reduce appetite. So there are only two ways to reduce appetite, sadly, and both not cheap. So one is the newer medications.
Is it Ozempic?
So Ozempic, which is semaglutide, or something called tirzepatide, which are the two we got here. They're both not currently registered for weight yet, but will be soon. They're still registered for diabetes, but they're the same drug. And then bariatric surgery, phenomenal, still the best in terms of long-term and most amount of weight loss. And that's because bariatric surgery actually reduces appetite.
Yeah, you're reducing the stomach.
No, that's what everybody thinks.
So I thought that you may
everybody thinks you're chopping the stomach, you make a smaller stomach. So it's not how bariatric surgery works. So bariatric surgery, so you rewire the bowel, and basically you're getting food down to a small part of the bowel where your body's own appetite suppressing hormones sit. There's quite a lot of them that sit down in the bowel. So when you get food there, these hormones go up. They do two big things. One, they help sugar. Two, they reduce your appetite. So the people who have bariatric surgery lose weight because the appetite goes down. So it's not because of a small shrunken stomach. Those self-same hormones that the body's making is now what Ozempic and tirzepatide are. They are those gut hormones being made into drugs. The only difference is they've taken those drugs, and those hormones get broken down very quickly in your body. They only last for a few minutes. But if you can make them hang around for longer and at higher levels, you're going to get that better appetite suppressing effect. So that's what they've done with Ozempic and semaglutide. They've made them into drugs.
What's the other one called, sorry?
Tirzepatide.
Okay.
So they've made those drugs resistant to being broken down, so you can get higher doses lasting for longer. You keep the body thinking that it's full, and so your appetite's down, and so now you naturally eat less. But it's not what patients call food noise. You don't have, when you're on a diet, people just think about food the whole time. One, because the appetite went up. Yeah. But two, they're sitting, how much do I have to weigh, measure, count? They have to think about it. So it just drives them nuts. Whereas when you've had surgery or Ozempic, that food noise goes out the door. So people aren't food focused. They just don't feel hungry. They just don't eat.
That's no different. It sounds like a miracle drug.
Because it's the right treatment for the right problem. So if you've got breast cancer, we go and chop it out. It's the right treatment for the right problem.
Yes.
If we were trying to treat you with herbs and spices, it would never get better because that's not the right treatment. Now we understand weight, so we give you the right treatment for the right problem. People lose weight. But then you get other people say, well, no, that's the easy way out. You're cheating. It's not cheating. If you've got blood pressure and I give you a blood pressure tablet, it's the right treatment, right problem, lowers your blood pressure. If you've got diabetes and I give you a diabetes tablet, lowers the sugar, you don't have to think or do anything. You just take the tablet and it works.
Are we starting, it makes me think of, I can't remember that movie that was on Netflix where people got addicted to a certain drug. So you got Ozempic and that other.
No, you can't be addicted to
No, but listen to what I'm saying. Yeah. So you got people that are pre-diabetic that are taking Ozempic and what's the other name again?
Tirzepatide,
okay? So they don't become diabetic. So you got that category of people. And then you got other who I just want to lose a little bit of weight. They can also be taking Ozempic.
So if their BMI is 25, and that comes back to the definition of how we define obesity, if they're 25 and they've got excess body fat and they're pre-diabetes, perfect. Don't have an issue using it. But someone else looking from the outside is going to say, but your BMI is 25, why are you using a drug? And I'm going to go, well, this is the reason why I do it. But if you're taking somebody who's got a BMI of 24, doesn't have excess body fat, doesn't have any weight-related problems, and now taking it, then that's aesthetic medicine. Now you're treating for body shape and beauty, but you're not using it for a medical reason.
Exactly what I'm saying.
But so that happens because that's always going to happen, because there's always access to drugs and someone is always going to get their hands on it. So we're not in favor of aesthetic medicine, because that's what that is.
But it works.
Yeah, of course, it'll work in everybody.
Cutting out your appetite.
Yeah, it will work in anybody. Correct. Okay. So if you're a model and you're sitting with a BMI of 21 and you've decided, I put on 2 kilograms and I just want to shed that quickly, I'm sure they're taking it. I have no doubt that there are models out there taking Ozempic to trim down 2 kilograms so they can look as they want to for their job.
And it doesn't create an addiction, I'll take it.
No, there's no addiction to it. No. So Ozempic and these drugs will only work while you take them. So that's the other big thing. So they're not a permanent fix. So surgery works slightly differently because you don't need to be on meds. But if you take Ozempic and say you lose 20 kilograms and you stop it, you will regain 2/3 of your weight in the first year, because it only works while you take it. So one of the problems is they're expensive. 2, if you're on it for time eternal. And in our heads, that's fine, because we see excess body fat as a chronic condition, like we do diabetes, like we do blood pressure, like we do any other chronic condition. We see it as something that you need to treat lifelong.
But okay, so you're managing the appetite, really, like it's like an appetite suppressor, basically. So then the person's losing the weight. So say they were 85 or 90 and they've come down to 60.
Yeah.
Okay. How do they maintain that 60? Still gain under 40. So are you cutting back on the dosage of
yeah, so you end up playing. So if you put somebody onto a drug, they'll always hit a new plateau.
Yes.
And then everybody, it depends where you start. So if you're weighing 200 kgs, you're unlikely to get to normal on drugs.
Yeah.
It would be very unlikely. You'll hit a new plateau somewhere. But say you were someone with a BMI of 28 and you were pre-diabetic and we got your BMI right down into the normal range, then we could play around and we could maybe cut back to a maintenance dose.
Okay.
But if I stop you, you're going to bounce.
So it's quite amazing that you haven't recalibrated or reprogrammed the brain on that appetite, even though you've changed. I mean, it's insane.
But it's like blood pressure. It's the same. We don't recalibrate you on blood pressure. We put you on blood pressure tablets. Your blood pressure goes down, and then it's fine. But if I stop the tablet, you go up. So we don't. So it's the same concept.
Yeah, but let's just look at this appetite thing. So, is that something that the person would have had as a child, or is it something that they've developed as an adult all of a sudden?
So you can inherit genes. So when we look at people and ask if you're very overweight from young, yes, you've inherited genes that are making you put on weight, and most of that is being driven by appetite. So yes, there is that. There are some people who are fine for many years and then only put up after school. So we see a big blip up after people leave school and then they go, and part of the reason for that is that exercise is a very good, even though it doesn't make very good for weight loss. Everybody thinks it is, but it's not. It's very good weight maintainer. So if you exercise and you maintain your weight, now when you leave school, what a lot of people do is they don't exercise as much. Their maintenance component is gone out the door, and now they start drifting. And then it becomes just part of a negative cycle. And then the other scary thing is this toxic environment and things can actually alter people's genes.
Okay.
So what they call epigenetics. So you don't actually change the gene, but you have something that's stuck on that modifies how that gene works or how it expresses itself.
So we're not knocking vaccines?
I haven't seen vaccine data for weight, but certainly stuff in our diet. So now the problem, say you've got a mother who's wanting to fall pregnant and her weight has gone up and she's got these epigenetic changes, these modifications to her genes. If she is overweight or obese during pregnancy, she can transmit those genes to children, which means now they become intergenerational or transgenerational. You can have a mother putting the baby at risk who then becomes overweight because of these epigenetic changes, and if that's another young lady that's born, she can have a child and then pass on those same genes. So now we have this.
And the epigenetic changes have come from our food, what we eat,
environment, what we're taking and stuff like that. Correct. So now you can pass it. That's why to fix the problem, prevention is a massive nightmare, because it's going to take generations to fix the problem, and with many changes.
But now you've got Ozempic.
So that's a treatment. So you've got to separate out treatment and prevention. prevention's a huge problem and it's going to take
sounds like
many
it's
years.
impossible.
But once you're there, it doesn't matter how you got there.
Yeah.
So the way I see weight is, it's once you get there, you can't reverse and go back out and try and fix the things that got you there. It doesn't work. Because once you've entrenched changes, they're not reversible. So now you have to go a different pathway, and that's a treatment pathway. So the path in is not the path out.
Talking about Ozempic, because I've seen different articles on Ozempic, and they say long-term use of Ozempic can cause major health issues. I mean, is that just...
So you've got to be careful about where you're reading and what you're looking at.
Yeah,
so
that's always the case.
Compounded Ozempic is a big problem.
What does that mean?
So compounded is not legal, and it's cooked up stuff, and we actually don't know what's in there. So it's not made by the company. It's made by somebody else who's managed to find the formula, and then we don't even know if they're making the right thing. They're making something, and they're putting it out there. So when you read about some of the side effects, you've got to be careful that you're not reading about side effects of compounded Ozempic or tirzepatide, because they're going to get side effects and we don't even know what they're reacting to, because we don't even know what's in there. But if you look at actual Ozempic, I mean, they've done lots of trials now. So we know that if you take people with diabetes and they've had heart issues with that, and you give them Ozempic, you will reduce their number of heart attacks, strokes, and they will live longer.
That's incredible.
If you give it to people who are obese or living with obesity, who aren't diabetic but have also had heart attacks and strokes, and you give them Ozempic, you also reduce heart attacks, strokes, and live longer. So it has a cardiovascular benefit besides for a sugar lowering benefit and besides for a weight loss benefit. So we know that they're quite good from that, and we like using them in diabetes quite a lot. If we could get everybody onto them, we would. And the
reason why you can't get them on, because it's expensive.
Cost. Yeah.
And the medical aids aren't covering it.
There are some under certain criteria who will cover it.
I mean, that's pretty strange, because wouldn't you rather, as a medical aid, pay for the medication than rather pay for the person to have a heart bypass surgery or stroke?
So you're wanting to bring logic to this party.
You mean there's no logic?
So that's not the logic. It's a pure rands and costings. I'm paying X amount this for on the medical aid budget or the medical scheme budget. I don't want to spend that, so no, we won't. So yes, the logical is that you want to prevent down the line problems and dialysis, which costs a huge amount of money, and bypasses. So yes, ideally you want to,
and cancer. Yeah.
So, but logic doesn't always work in terms of how it gets funded. So ideally, yes, we would put everybody, if we could, onto them, and people even who aren't diabetes or are obese and have heart problems, them again as well, because it's not only fixing and helping the heart problems or reducing the risk, you're helping all the other weight-related problems. They've got snoring, fatty livers, osteoarthritis, other things that you will improve by getting weight loss better. So improving weight loss improves a whole lot of things. So they're very nice drugs from that point of view. Are they perfect? There's no drug that's perfect, so they do have side effects. So
what are those side effects?
So the common side effects is nausea. Mostly temporary, gets better. You might get the odd one to have more nausea, but it can be anything bowel related. So you could get constipation, diarrhea, abdominal pain. So you can get things like that. And you're always going to get a group or a small number, and it is a small number, we get much more serious side effects, but that's no different to taking Disprin, where if you take a lot of Disprin, you can cause a stomach ulcer and bleed out and die. People still take Disprin, they don't complain. So everything does have a side effect. And when they look in the studies, they always look at the risk benefits. They're looking at how many side effects you're having to how much benefit you're getting, and it's always on the side of benefit. So there are side effects, but they're not as made up, they're not as dramatic or as played out as they are on the internet. And again, just got to separate out compounded and proper stuff, because that message is often confused.
Yeah, it's distorted. Okay, that's quite interesting. I mean, reading. So for people that have got a bit of money, that are struggling with weight gain and all these kind of things, then Ozempic sounds like.
So Ozempic, this class of drugs, these gut hormones. So they've got combinations. So tirzepatide is 2 of the gut hormones. They've got a triple combination coming out, which loses even more weight. So as they combine these hormones, they get you to lose more and more weight. So probably in a few years' time, we're going to have a whole lot of these hormones available on the market. You can get them in tablet form already, which I haven't got here yet, but injectable or tablet form. So there's going to be a whole lot of these.
So what is available now? If I say to you, when I'm pre-diabetic, I can afford it. I want to buy.
So in
take
this
Ozempic.
country, we have semaglutide, which is Ozempic, and we have tirzepatide, which is Mounjaro. Both are currently registered for diabetes, not yet for weight. They get used off-label for weight, but registration for both of those for weight loss will happen in this year. And so then you'll be able to get either one of those, Ozempic, the single hormone, or Mounjaro, the double hormone. They'll probably have different names. So the companies name them differently, whether they're used for diabetes or weight.
Okay.
Drives me crazy.
Is it a tablet though, or is it
no,
injection?
injectable, once a week injections.
Okay.
So they're used via the same devices as you use insulin, those syringes or those pens.
You stick it into the muscle.
No, subcutaneously, small little needles
Okay.
just under the skin. So you could use stomach or legs.
Okay. And how much are they at the moment? I mean, this is
They're
2025.
pricey, so you could be
June
paying
25.
Yeah, so it depends on the dosage, but you're going to pay anywhere from $2,500 to $5,500 a month. So they're expensive.
Depending on the dosage.
Correct. Depending on which molecule you're using and which dose you're using, but in that ballpark. So it's expensive. So we want cost to come. Now, obviously, patents will go, and that will
You'll
help.
have generics coming up.
Generics come in,
Yeah.
and if you can get tablet versions, those are easier to genericize, so then that will hopefully get the costs down. So in a few years, we'll have a lot more availability of different hormones and molecules, but also hopefully cheaper with the current ones we have got.
So the people that basically is the people that can afford it, they'll take Ozempic, and that'll manage their weight problem. The weight problem will eventually manage the diabetes issues.
Correct.
Etc.
So it's the usual
the other
socio-economic issues where the rich can
Yes.
afford the treatment,
Yeah.
but the poor who need it can't.
Yeah. So for the other majority of the people, are they on just your normal glucophage?
So they'll get their normal, diabetes treatment, but they're not going to get the Ozempic. So in state, for instance, you're not going to get that at all.
Not going to get what?
You're not going to get Ozempic or Mounjaro in state. So if you
the
have
States?
diabetes, no, in
in the States.
yes,
Sorry.
as
Okay, in the
opposed to
States.
private, but in the state hospitals.
Yes.
So
You're not going to get it, of course.
Krusky,
Okay.
Tigerberg,
Yes.
and
No.
all of those, you're not going to get these.
Yeah, you'll pay for it if you're on Discovery, Coastal Saver, or whatever. You're going to just go and buy it and pay for it if you've got the money.
Correct.
Okay. And if you don't have the money, then you stay with your
Normal,
glucophage.
glucophage, and diaglycide, and all of those.
You
correct.
seem like
So
you've given up
tablets.
hope on those.
Well, but they're nice for lowering sugar, but they don't bring cardiovascular benefit. So these new medications, these hormones, lower sugar, lower weight, but also bring cardiovascular benefit.
Okay. So so that if you're lowering sugar and you're lowering weight, the normal medicines, why aren't they reducing
No, so like
cardiovascular?
metformin, then all they'll do is lower your sugar. They won't lower your weight.
Yes.
But by lowering the sugar, they don't make you live longer. So the new drugs will lower sugar, but in addition, besides for lowering sugar, they help heart and reduce heart attacks and strokes. So you've got a drug that lowers sugar and benefits heart, as opposed to a tablet like metformin just lowers sugar but doesn't do anything for heart attacks and strokes. Which is ultimately what we want to prevent.
Okay, sounds like a stupid question. So if my weight is okay, but I am diabetic, and I am taking metformin or glucophage to lower my sugar levels, why do I still have the risk of cardiovascular disease, of this heart attack and stroke?
Because type 2 diabetes is not a pure glucocentric condition. In other words, type 1, your problem is you've got an issue with just sugar. Your glucose levels are high because your pancreas doesn't make enough. It's a pure glucose problem. In type 2, the problem is not a pure glucose problem. It's a metabolic problem. You have sugar, blood pressure, cholesterol, excess visceral adiposity, so fat in the wrong place. So it's multifactorial. So you've got more than one thing happening. So you can just lower the sugar, but that's not going to be enough. You need the blood pressure down, the cholesterol down, the weight down.
So you need to take a tablet for all the different things.
And the only thing that's going to help all of those is getting weight down, because that's going to help your sugar, your blood pressure, your cholesterol, your fatty liver, all of those things.
Okay.
So type 2 is a very much more difficult problem to treat when you're looking at heart, because it's many things going on. So Ozempic is just treatment. It doesn't prevent you from getting overweight in the first place. It just, once you're overweight, now it helps you to lose.
Yeah, but what you've told me about getting overweight in the first place, it could be
So we know reasons why you get there, but trying to stop those.
Yes.
So we know it's food and the toxic environment, but changing that is is a
But
problem.
but basically, I heard you say also it's impossible, nearly, because once something's changing your genetic makeup.
So correct. So if the food is part of the reason that causes the problem and affects the appetite, once that is entrenched, you can't now undo it.
Yeah.
So now all you have is a treatment option.
How many people do you think know about this? I mean, exactly like you said it, because I don't think it's really out there.
No. So the story has to change. So we know that most people don't know that. So no, we bring out new national guidelines. So in that will be the sort of explanation of how we understand how weight has happened and why people are overweight, and it's not their fault. It's part of the process of living in this lovely environment.
Thank you, Wayne. I think you've explained it pretty well. I mean, I've learned a lot, in terms of, we manage discovery health claims for a lot of people. So, and some of those people are diabetic, and some of them have had triple bypasses. So, it's it's good to be informed, because you can inform other people.
Yeah.
So for a person that wants to go on Ozempic, what do they need to do? So they
See
take
their
the
doctor,
diabetic
get
type 2.
Yeah.
Can you get it from your normal GP? Do you need to come to a specialist like yourself?
No, you should be able to get it from your normal GP. So it depends on the GP and how comfortable they are prescribing, but if they're comfortable and they're happy, then you can get it from them.
Why wouldn't they be comfortable?
Some people are just uncomfortable, and some people have different opinions about weight and don't think that you should be taking a drug for your weight. You must just go and diet and exercise. So it depends on the GP that you get.
Is the GP informed enough about, that's what you're saying.
Correct.
Yeah.
So we do a lot of talks, and hopefully our guidelines will change opinions. But yeah, so it does depend on who you get.
Thank you. Thank you, man. I appreciate it.
Pleasure.
Thank you, man. Thank you.
Pleasure.
Okay.